rehab. So what is it? It's something that is newer, underserved for sure. It could be put on by a physical therapist, an occupational therapist, and doctors are really now starting to pick up on it more when you're going to see them. And then the Academy of Pelvic Health, their mission is just that we are changing the conversation and perception about the pelvic and abdominal issues worldwide. These are very sensitive topics, and they can be very embarrassing topics if you don't know that they're common. So we kind of want to flip the script there and let everyone know that it is okay, and then we can do something about it. So our objectives, we're just going to talk about anatomy and function, so you'll figure out where the pelvic floor is. We're going to do a little screening tool with everyone just to see if you do qualify for a pelvic floor dysfunction and what you should do if you are screened positive. We're going to go through what a typical evaluation would look like if you came to see us, and then examine common pelvic floor disorders and treatments. Our presentation is geared a lot towards women, but we do see men as well. We just wanted to put that out there too.
So to go into a little bit about what in the world are these muscles, what are we talking about, where are they located, we're going to go through some anatomy and function. Again, this is really geared towards a female pelvis, but recognizing men have pelvic floors too that work in very similar ways, just with some different anatomy. So here we have a cross section of a female pelvis, and I'm going to come up here and kind of point if that's okay. We have kind of our pubic bone here in the front, and then on the back side there, we see the tailbone coming down, the coccyx. And then this sling of muscles right here in the middle, that's our pelvic floor. So they surround very important structures, urethra for females, the vaginal canal, and then the rectum. And they're going to have many important functions, some of which involve these muscles tightening and giving us some more support and some more control over bowel and bladder. And then sometimes we need them to relax as well. So usually when something's going wrong with that order is when we end up seeing people. This is kind of an overhead view. This overhead view would look pretty similar in males and females, just with different size of a pelvis typically. But they really span from the front to the back and side to side, like this big bowl of muscles at the bottom of your pelvis. So when we're treating these muscles, we do also want to treat the structures around it. So we end up looking at the bony pelvis, the muscles around the pelvis on the outside. There's a lot more that goes into it than just what people would say are Kegels. You know, there's a lot more to it that we're treating. And speaking of the bony pelvis, this is just a quick kind of review over what those structures are. So we have the ilium of the pelvis is this big like elephant ear part of our hip. The words here go through, it's a little bit different size, shape in females versus males. We have the ischium, which is kind of that sit bone you can feel when you're sitting there. And then we have our pubis, which is like the bone in the very front. And the pelvic floor muscles do span from each of these attachment points, so we need to consider where they're located when we're treating them. The back side of the pelvis is another area we need to consider, where our back comes down and kind of meets our pelvis there, the SI joint. That's where a lot of people have a lot of pain, and when we have pain going on, the pelvic muscles tend to really react, whether that be weakness, they're just kind of shutting off working, or tightness, they tend to tighten up. So we want to consider everything on the back end too. So that's going to include our sacrum. It's right in the middle, the one with the little holes in it. There are these fused vertebrae, makes a very stable structure. At the very bottom of that is our tailbone, or called our coccyx. Pelvic floor is going to attach to that structure. So if you've ever fallen on your tailbone or had a tailbone injury, sometimes the pelvic floor can be affected with that. And then the sacroiliac joint, so where that sacrum is meeting your ilium or that other part of your pelvis. Sometimes we can have dysfunction there where it's not moving correctly, and that can influence the pelvic floor and pain experiences as well. Now we'll talk about the function of the pelvic floor. So one of the handouts we passed out goes through these if you want to follow along on that. But sexual function is the first thing we'll talk about. So when these muscles relax, that for females, that allows penetration and pain-free penetration. A lot of people who are having painful sex, this tends to be because these muscles are not relaxing well. And then for orgasm, we need these muscles to contract really strongly. So if they're having trouble doing that because they're weak or because they're already super tight, we're gonna have a difficulty or decreased quality there. Sump pump effect is kind of a fun name, but essentially as we breathe and take deep breaths and our diaphragm moves up and down up here in our upper abdomen, our pelvic floor is responding as well. So that creates this like pressure change as we breathe that's gonna influence blood flow, lymphatic flow through the area as well. Support. So we saw in that cross-sectional view, the pelvic organs really rest right on top of the pelvic floor. So we need those muscles to be able to give some support to these organs when we're doing things like standing, exercising. If you have a job where you stand a lot, yard work, lifting, we need these muscles to give us a lot of support. When we aren't getting good support, that's what can lead to some things like pelvic organ prolapse, which we'll talk about in a little bit. Stability. So when our pelvic floor contracts, we have this muscle in our belly called our transverse abdominis, that when it contracts with the pelvic floor, it really stabilizes our low back and our pelvis to decrease risk of back injuries, hip injuries with movement. And then we have bowel and bladder control, or the sphincteric control. So we saw the muscles surround rectum as it passes through, and then urethra. And so we need these muscles to be able to contract when we don't want to use the bathroom and to relax when we do want to.
All right, so we're gonna go through a little screening tool here. This being said, it can be embarrassing. So if you want to raise your hand like, oh, yep, this applies to me, go for it. We love the participation. If you want to be more reserved and like kind of think in your head and talk to us later about it, that's perfectly fine too. Just want to give people the options there. So our indications for pelvic floor rehab: any type of incontinence. This includes gas, fecal, urinary, or difficulty voiding, constipation, not being able to get all that pee out when you're going. Those are things you would come see us for. Any type of pelvic pain with penetration, and this includes your gynecological exams, tampons, discs, anything, especially as a female, you're trying to insert something. If that's painful, that's not normal. We can work on some of that. Any type of pelvic pressure, heaviness, bulging. If your doctor has talked to you about prolapse and they say that you have one, you can come to us for that as well. And then any type of sexual dysfunction. And we're gonna say it a million times. Sure, it's common, but it's not normal. I'm gonna give a little story about my mom. My mom has 5 kids. And when I started getting to the pelvic floor world, she's like, Taylor, it is so normal that I pee every time I cough. And I'm like, Mom, no, it's not. I'm like, I don't want to treat you. I'll have someone else treat you, but not normal. She still argues with me, but I'll get there someday. So this is our little screening tool that we use sometimes. By the time people come and see us, pretty common that they already have this screening tool done. This is something that your doctor might work through if you're seeing your primary care physician. But if you have 3 or more yeses, then we would probably suggest you come see us and at least get evaluated and see what we can do for you. So these are all just going to be like patient scenarios. So sometimes I have pelvic pain in your genitals, perineum, pubic bladder area, any pain with urination, and it exceeds a 3 out of 10 on the 1 to 10 scale. 1 is a little bit of pain, 10's like send you to the hospital type of pain. So if it's above that 3 and it happens often, you should come in and see us. If you ever remember falling onto your tailbone, your lower back, or buttocks, you might think that it's a lower back problem when it actually could be your pelvic floor. During an evaluation, we would look at total body. It's not just your pelvic floor muscles that we're going to be assessing. Sometimes I experience 1 or more of the following urinary symptoms. Urinary symptoms are our most common thing I would say that we see, but that's accidental loss of urine. You don't feel like you can make it to the bathroom in time. You're having to wear pads or some sort of protection. feeling unable to completely empty your bladder when you're sitting on the toilet, or if you feel like you just went pee, you get up, you do something, and then you have to go pee right again. Those are some things that we would be working on. Any pain or burning with urination. Sometimes that can mean infection, but if you're seeing your doctor and they're sending you to me, hopefully by then we're getting that figured out. And then difficulty starting or stopping that flow of urine. You want to be able to have the strength to do both. But a little pro tip here, don't just go stopping your flow of urine, because that'll create some problems in the future too. If you have to urinate more than 2 times at night, we want to work on spreading out those voids. If you have a feeling of increased pelvic pressure or sensation that your pelvic organs are falling down or slipping out, we're going to work on some prolapse release, some pressure management. If you have a history of low back pain, hip, groin, tailbone pain, or have had bad sciatica, a lot of things that we do is we look at pelvic alignment, and that goes into your lower back as well. If your back or your hip or your tailbone is all out of whack, you're lining up wonky, it tends to be that those muscles are being stretched out or being shortened in the way they're not supposed to be. And then bowel symptoms too. If you have a loss of bowel control, same thing. You're not making it to the bathroom in time, or you get a really, really big urge, like I have to go right away. You should be coming in to see us. If you feel unable to completely empty your bowel, you go, but you just feel stuck and you feel like you have to sit there for a while, we're going to work on that. Any straining or pain, working on decreasing some of the constipation there, and difficulty initiating a bowel movement. If you feel like you've gone days and days and you don't even get the sensation to start, then we're going to work on that too. Pain or discomfort with sexual activity or intercourse, or if sexual activity increases one or more of my symptoms. And then prolonged sitting, because if you think about it, you sit on your pelvic floor all day long. We want to be sure we're getting up, we're moving around, we're stretching those muscles out instead of just pressure all the time down there.
Okay, I'm going to talk about how we evaluate the pelvic floor and what you could expect if you came in for an evaluation. So I get a lot of people who come in for an evaluation and they are nervous because they don't know what to expect. They just hear this thing about a pelvic floor. They're going to talk about some very personal symptoms. And I like to, my very first thing, tell them, mostly we're going to talk today. I want to get to know you. I want to get to know what you've been experiencing. I want to educate you on the pelvic floor, because a lot of people, by the time they get to us, they haven't had a lot of pelvic floor education. A lot of their providers have told them, hey, you need to go do this thing, but they haven't really told them what that thing is. So that's kind of the first place I like to start. So with this subjective history component, really it's a lot of questions. It's really just getting to know you, the extent of your complaints. We do tend to ask about urinary, bowel, and sexual history and experiences. We do tend to ask about what your biggest goals are, because with the pelvic floor, we can work on a ton of things. But we want to get to know what you're really trying to get out of it most. Once we've done the subjective history, we get a good idea of what's going on, we'll start our physical exam. So with that, there's some options. For sure, we want to look at your spine, we want to look at your pelvis, we want to look at your strength, range of motion, how well your body's moving and supporting those internal structures. But then we also have the option to do an internal exam, and this is actually assessing the pelvic floor muscles. So for women, this can be done vaginally or rectally. It's not like at the gynecologist. We're not using a speculum. We're not using stirrups, nothing like that. You're covered up the whole time. We really explain the whole process before we do the exam. The only time we'd typically do a rectal exam is if your symptoms are rectal in nature. So this would be if constipation or fecal incontinence are your main concern, if you're having tailbone pain, rectal pain, those sorts of things. Otherwise, for women, we typically do a vaginal exam. And for men, our access point is rectally as well. Typically in this exam, we're doing some palpation, so it's going to be just feeling the muscles. Typically, things that come in or out of the pelvis are not pushing sideways, and that's where these muscles live. So we're going to feel sideways into the muscles and just see for you, are they painful? Are they feeling tight on my end of things, like they have more tension than they should? And then we'll do like a function test. So I would have you try to tighten the muscles as well as you could, hold that as long as you could. I'm gonna feel how well do you let go, and that's gonna let me know what do we need to work on to fix your complaints. After we do that, we're gonna do lots of education. So this little blurb here doesn't even cover everything that we would educate on, but we'll generally talk about what do we think your symptoms are coming from. What things are you doing every day? So toileting is an example, but other things we would look at are pressure management. How are you lifting things? How are you moving your body? How are you breathing? That we can immediately get started on until we can fix the muscular dysfunction. And then we'll talk about our plan of care. So usually for women's health or pelvic health, we're seeing people for about an hour. We like to have that long of a session to be able to really go in depth on what we're working on. Because it's a lot of education. But then length of time, it really depends. Typically a pelvis that's dealing with weakness and tightness as an issue, or has more than one area of complaint, so bowel, bladder, and sexual maybe, it'll take a little bit longer versus some people with just one complaint or maybe pure weakness is the issue, that may take a little bit shorter. So we like to talk with you on frequency, duration of care, those sorts of things. This doesn't really fit in this section, but this is kind of a underneath view of the pelvic floor. And as we're assessing the pelvic floor and doing that internal exam, we're kind of going by this clock system. So the 12 o'clock is going to be straight up. So in women, that's going to be the clitoris or the pubic bone. And then straight down, that 6 o'clock is gonna be rectum and perineum, so that area right between the two. And we're using that kind of as our landmarks of where we document where you're having pain, maybe where some of the dysfunction is. For some people, one side is kind of holding more tension than the other, one side is stronger than the other, so we'll kind of note any of those differences. But even though we collectively call it the pelvic floor, as we see, there's a lot of different muscles here. So on our end of things, that's where our brain is trying to determine which muscle is the problem.
All right, so let's get into some incontinence. We're gonna talk a little bit about urinary, the different kinds there, fecal and flatulence. So what is urinary incontinence? It's just an involuntary loss of urine. This could be with coughing, sneezing, it could just be walking, hearing the flow of water and you automatically have to pee. As you can see the incidence there, as we get older, it tends to get worse. Part of that is menopause and the loss of estrogen in our body, and we kind of lose that strength down there. It is interesting in nursing homes too. If you don't use it, you lose it. So you want to keep moving, you want to keep active so that we're staying strong and keeping these muscles strong because they're important. So different types of incontinence. We have our stress and we have urge. Stress is more of what I was talking about with my mom. She sneezes, she laughs, she jumps, she's going to leak a little bit. And some people it's a little bit, some people it's a lot. And after childbirth especially, everything gets stressed out, everything gets changed. You got to work on getting those muscles back to normal. But that's just that change of pressure causing the urine to leak. And then we have urge. So you get a strong, oh my gosh, I got to run right now, got to go. Most people say running water. They get home, they have that key, we call it key in the door syndrome. I have to go to the bathroom right away. Or even just walking to the restroom because your body, your brain connection to the bladder is telling you, oh, we're going there, so let's go. We're gonna wait a little bit on that. You can have mixed too, so that's urge and stress together. And then some others are postural. So if you're going, every time it happens, it's going from sitting to standing. There's something going on there that we need to address. And then nocturnal, which is involuntary loss of urine during sleep. And then just continuous, you have no idea when it's coming or how it's gonna happen. So these are some goals we might come up for someone with urinary bladder symptoms. So we want people to urinate every 2 to 4 hours throughout the day. Sometimes we would like to stretch that out a little more, but we only want like 0 to 1 times at night. And you should be peeing 5 to 8 times during the day. So if you're looking at this and you're like, man, I have to go every hour, that's something that we can talk about and make goals on. You want to be able to pee for 8 seconds or longer, and that stream should be it should stay. It shouldn't be like dribbles and then you wait and then it comes. We want it to be a solid 8 seconds. This one's a hard one for people. You want to avoid that just in case pee, especially if you're someone who does have some urinary incontinence. They're like, oh, coming in today, someone may have used the bathroom before coming in because they're like, I really don't want to use the bathroom while I'm in there. You want to avoid that because it's teaching our bladder bad habits. You don't want to strain or push. You want to make sure you're drinking adequate water. Water is really important. Juice, caffeine, that type of stuff can irritate the bladder and make us have to go more often. So those are some of those bladder irritants there. And then you want to keep up with exercising. Some interventions we might use. Big one is bladder diary. So a lot of people, I ask them, how many times do you pee a day? And they're like, I have no idea, which is normal. I don't know if I could tell you how many times I pee a day, but I would give you a nice diary and you would write down when you peed, what time it was, and how long it took you to pee. And we can kind of talk through that your next visit. Just normalizing how often you go, managing fluids. Fluids is a big one for a lot of people. Performing what we call the knack. So if you're someone with that stress incontinence and you know every time you cough, you're gonna leak a little bit, we'll teach you to do a Kegel, which is pulling that pelvic floor up and in, and both men and women can do this. You do that and then you cough, and it helps that sphincteric control there. Using urge suppression techniques, if you feel like, oh my gosh, I have to go, you gotta be patient and just do a couple heel raises, which is very hard and it takes some time, but we'll work towards that, and just pressure management. Constipation is a big one. If you're constipated, you have so much pressure down there, it's gonna cause you to leak more. We could use biofeedback, which we'll talk about a little bit later. Pessary, which is if you have prolapse, it's a nice little brace almost that they would your doctor would internally insert to kind of help manage the pressure, and then as you get stronger, you kind of wean off of that. And then different medications and surgery can help as well. So anal incontinence, this would be stool. It's more common in older adults. Again, you're just losing that strength in the posterior pelvic floor, and we need to work on that a little bit more. Some risk factors are anyone over 65, you're not moving, you have chronic diseases, smokers. With smoking, it's going to really affect a lot of your body, so you want to take that into effect. And then women of childbearing age, and they have a grade 3 or higher perineal tear. The tears just make everything weaker and it's harder to control. And then gas. 1 in 3 women over the age of 30. Your diet can affect this. Again, with the tear, everything's weak. You can't really squeeze. Obesity, and then menopause, because you're starting to get more lax because of the lack of estrogen and progesterone in your system. And this is that example of that bladder diary I was talking about. So as you can see, we have all of our times written out. You would write down your food and your fluid. I usually don't have people measure how much they void. It just doesn't. I don't like using a hat, and I'm sure no one else does either. So, but I'll have you count 1 Mississippi, 2 Mississippi. It's not just a 1, 2, 3, 4, 5, 6, 7, 8. And then what activity you were doing if you leaked at that time.
Okay, moving on, we're going to talk about pelvic organ prolapse. So this is when parts of our internal organs, so for women, this is going to be that bladder, rectum, or vagina or uterus, can start to fall into that vaginal canal. More common, I don't really hear of men getting prolapse happening. They can have like a rectal prolapse, but in the instance we're discussing is more female directed. So the definition of pelvic organ prolapse: when we have lost support to the uterus, bladder, and bowel, which leads to their falling or their descent from their normal position towards that vaginal opening. So this is going to feel like pelvic pressure. This is going to feel like something falling out. For some women, this feels like pain. And I meet a lot of women who don't even notice it. So down here we have prevalence. Based on symptoms alone, from wherever these statistics were taken from, it was only 3 to 6% of people that had prolapse symptoms. However, when we did a pelvic exam, about 50% had some evidence of prolapse. So I meet a lot of people who are coming in not even for prolapse symptoms themselves, they're coming in for this bowel or bladder dysfunction, or maybe pelvic pain, or maybe I'm treating them postpartum. But we find that prolapse is part of the discussion, part of the conversation, and part of what we need to treat. Things we can do for pelvic organ prolapse, physical therapy is one of the #1 things we can do. So prolapse tends to come in different grades and stages. When it's in those, there's 4 stages. When it's in the more mild stages, 1 and 2, meaning the descent of the organ is not coming past the vaginal opening, just to it, that's when PT is really one of the more successful treatments. So with this, we're gonna work on pressure management. If we are constantly holding our breath and not using our core and not moving appropriately, our body's gonna direct a ton of pressure down towards the vaginal wall, and it's gonna encourage those organs to fall further into the vaginal canal. So we're gonna try and fix our breath, fix our lifting mechanics, strengthen ourselves in areas we're not strong. If the pelvic floor itself is weak, or if it's tight, we're gonna work on normalizing the function of the pelvic floor. I can see people with tightness or weakness having prolapse. So that's where that exam we do in our evaluation comes in handy in guiding us. We can use gravity eliminated positions, so laying on your back or laying on your back with your bottom up on some pillows or getting your feet up. This tends to let gravity help pull those organs a little more internally, and it takes the pressure off of the pelvic floor and off of the prolapse. I find this to be more helpful if you are really experiencing that pelvic heaviness, pelvic pressure sort of a feeling, can be pretty useful. Glute exercises, so that's just saying we want to strengthen the pelvis itself. Typically, if our glutes and our hip muscles and our core are not strong, the pelvic floor is going to take more of the brunt force. We're going to start moving in weird ways, can create more of that pressure towards that prolapse. And then we're going to see, how are you using the bathroom? The toilet is a really unique seat setup where there isn't anything supporting the pelvic floor, and their gravity can pull organs kind of in that lower direction. This can be felt a little bit worse too if we're constipated, if we're straining. If some people use a technique called splinting, where they actually use their hand to support that prolapse to be able to use the bathroom. So we'll kind of go through what are techniques you could use for that to kind of help with the difficulty. Some people with prolapse find that with toileting, they can't empty because the prolapse is physically in the way of allowing that bladder or bowel to empty all the way. So we'll work on what are ways to help improve that. And then we'll talk about lifting techniques as well to avoid that downward pressure. Beyond therapy, though, there are some typical medical management. We have those pessaries that Taylor was talking about. So these are, internal devices that are supported or inserted vaginally that give support to the prolapse. And I know some people that just have those all the time. Like they just have one in, and that's just how they live their life, and it helps them. I also meet some people who try it and they don't like that, or they're not interested in trying that. And then we have surgical management as well. So they do prolapse repairs also. I do find that with the pessary and surgical management, pairing those with PT, especially the surgical management, can lead to greater success of the surgery. So I will meet so many people who have had a prolapse repair, and then years down the line, they're coming back saying, I have prolapse again. Well, it's because we never fixed the issue. We never fixed what was causing the prolapse in the first place. So I find pairing this, at least with the surgical management, can lead to better outcomes as well.
All right, so getting into some pelvic pain. So this could be lumbopelvic, so lower back, hip pain. It can look like pain with intercourse, which is called dyspareunia. 10 to 20% of people during the course of their lifetime will experience this, whether it's later on in life when they're losing that estrogen and things aren't moving the way that they used to move, or they've never been able to do something like this because those tissues never adapted. And then we have vaginismus, which is an involuntary muscle spasm of the pelvic floor with penetration. A lot of time we're gonna work on relaxation techniques there. A lot of people hold stress in their pelvic floor, so we're gonna work on a lot of relaxation when you come to see us. So in the interventions, so we'll use some manual release. Usually that involves either our finger, a wand. We have other things that we could use to kind of get those muscles to relax. We find what we call trigger points within the muscle, which is like a big knot. We think of those all over our body. Our pelvic floor gets those too. Autonomic nervous system down training. So the nervous system that we can't control, we're gonna learn different techniques that, hey, I'm stressed out. Maybe I need to do some breathing and some thinking and stretching to try to calm that down in a way without, we can't really turn our brain off. Biofeedback for relaxation. So biofeedback is a tool we use. We can use it externally or internally. We have different sensors there. But what it does is it gives you a reading on how tensioned your pelvic floor is. For some people, we'll work on the relaxation, whereas other people, we work on the strengthening piece. But it gives you like a visual. If you're a very visual learner, you can look at our screen and you can see, wow, I'm starting at a 10 and I need to be at a 2. And that's a great way to kind of manage that yourself too. Pressure management, dry needling, which is the use of acupuncture needles in tight muscles. Neither of us are pelvic floor dry needling certified, but I know some people that are. If you're interested, just let me know. And then different tools, so pelvic wands and dilators, and we'll talk about that more now. So dilators are on the left there. Those are used if someone's working on insertion. So for example, a tampon. If a girl comes in and she's like, it's my goal to be able to use a tampon, I've never been able to, it's really painful. We're gonna start at that lowest level there and slowly work our way up. It's a progressive stretch that we could use. Same thing with pain with intercourse. You'd work up to the size that your partner might be, so that way you can actually enjoy it rather than feel like you can't, or you feel like you're suffering through that. We get a lot of stories like that. On the right there, we have a pelvic wand that can be used both rectally and vaginally to work on those trigger points. You find that tight spot, you hold it there, it stretches it out, and it's a good way for you to kind of keep up with stuff at home. We'll teach you all the tools you need so that way you feel comfortable with all of this. Here's that biofeedback. So as you see here, it kind of reads how many seconds the sensor was in and how much pressure that pelvic floor has. We would want a resting tone to be a little bit lower than this. This person is pretty tense, as you can tell. And then we can do exercises with this inserted as well. So this one's working on strengthening. So they're holding that Kegel for 5 seconds. As you can see, as they start to go on, as they're doing more, they get weaker and weaker. Their endurance isn't very good, and we see this a lot with people. So that's something that we would show you, talk through, and work on, making goals to get better at that. And then the same thing here with a 2-second hold. So those are like quick flicks, Kegels, holding for 2 seconds. And that person actually did a pretty good job at maintaining that same strength all the way through.
All right, we hanging in? Just got a few more topics to cover. Okay, it's extensive, as you see. Even within pelvic health, there are a lot of subtopics. So constipation is one I'm rather passionate about. I find it affects so many more people than we ever talk about, but really, really impacts how much pressure is going into the pelvic floor and into those pelvic organs. So let's talk about what is normal, because constipation can mean very different things for different people. It doesn't just mean, hey, I don't go every day. Typical range I see for people is anywhere from 3 times a day to 3 times a week. So it really can be this big range that we see. Now, if you're, say you're an everyday person and that is your norm, and all of a sudden we drop down below that, that for you would be constipation. But if you're a 3 times a week kind of person, that's not necessarily bad. It's just your body's norm. Some things that would indicate constipation, though, is if we're straining. So normal bowel movements, we should not have to push those out. They should be able to come out right on their own, no matter the consistency here. They should not be painful, and they should feel complete. So if you're feeling like bowel movements really hurt, I kind of have to push them out, or I'm not feeling like I get everything out of me, those would all be signs of constipation. And as I had said before, these can cause that increased stress on the pelvic floor. So fun pictures. So you can't see the words on this very well, but with everyone I'm meeting with, even if I'm not seeing them for constipation specific, I'm getting real personal with them, and I'm asking them, what does your poop look like? Give me some detail, because we want something right in the middle here, this type 3 and type 4. Those consistencies should be able to come right out without pushing. Anything below that, that's where we're going to get into typically some difficulty controlling the stool. But I do meet people where we're down in this liquidy end and they're having to push that out. They are having to strain even with that. So that's telling me the exit point is having some issues. And then I meet people where we're up in this higher category, things are more firm. That's going to be a lot harder for the body to get out. So we're going to have to strain in that case. So in managing that, one of the first things we're going to look at is consistency. If you're up in that higher category of firmness, we're going to start working on things to start to make that a little bit softer, a little bit easier to evacuate. So that's going to be water. So for an average person, recommend somewhere between 80 and 100 ounces of water. That's a lot of water. That's a lot more than most of us consume. If you are larger than the average person, I would recommend more. I drink a lot more than that, or try to. Or if you're smaller, more petite, we'd recommend less. And then fiber. The recommendation is 25 grams of fiber a day for women. That is also a lot of fiber. It's a lot more than we're usually getting in our everyday American diet. So it can be something that people say, oh, I eat great, I eat plenty of fruits, vegetables. But if we really dive into how much fiber is in those, how much water are you getting, sometimes it's not quite where we want it to be. So those are some things we can mess with. Beyond consistency, or how easy is the stuff to get out that we're trying to get out, we want to look at motility. So our colon is designed to draw water out of the stool. The longer it sits in our colon, the firmer it's going to get, the harder it's going to be to get out. So we can do things like abdominal massage. Exercise itself gives some different pressures into the abdomen, which help propel things through. So those are some techniques we can use just working on how smooth everything's passing through your colon. And then emptying. So I talk with a lot of people who tell me, yeah, I strain all the time. That's just how I go. That's my normal. But that's not normal. So we want to look at how are you sitting, what technique are you using. Most people I meet do this breath hold push sort of situation. So we'll work on, I encourage most people to blow out as they're kind of trying to go. And this can help the muscles relax a bit better. And then also, if someone just has generally a tighter pelvic floor, we'll work on some of those interventions we talked about for pain, where we're working on relaxing the muscles. That's another aspect we can treat.
We also see pregnancy and postpartum women. Common things that we see are pelvic and low back pain. You got a lot of weight up front, your back's gonna take the brunt of it. So we're going to work on that, working on birth prep and recovery for a C-section or vaginal birth. There is a push now for use of doulas and use of different birthing techniques. So we'll talk through that, we'll educate them and see what they want to do, because it really is a personal experience there. We'll talk about body mechanics for carrying or feeding, because if you think about it, you're a mom, you're looking down all the time, your back's hunched over. That's going to cause some pain there. And then core rehab. Emily will get into this in a little bit, but a lot of the pelvic floor is your core. From here down, all of that's going to be really important. So that's what we got there.
So this is talking a little bit more about the abdomen. So we'll talk about what's called diastasis recti and then hernias as well. So we can go to the next one. Diastasis is this separation of the abdominal wall. So our big rectus abdominis muscles on either side, our six-pack guys, they tend to just separate out from each other. There's no hole in the abdominal wall for this one. They're just a little separate. Very common in pregnant women by the end of their pregnancy. For some women, this doesn't heal down all the way. It can stay kind of separated. That being said, I meet plenty of women, and honestly more men than women, that have this type of a separation. So it can be pretty common. You may notice with this type of a separation, this doming or this coning up in the midline of the abdomen when you do things like sitting up out of bed or trying to look at your toes if you're laying in bed. Some people with exercise notice that kind of doming up. We don't want that to happen. That can put us at risk for developing a hernia, which is the next thing we'll talk about. So the hernia is the actual hole in the abdominal wall, and there's a lot of different places these can develop, but it's a pressure issue. So the structures on the outside of our abdomen, obviously we're not strong enough to handle the force we were using, the pressure we had inside, and it just poked a hole through. If you go to the next slide, I have pictures of each of these. So the diastasis we see here on the left is just that separation. That structure in the middle just got thinned out, it just spread out a little bit. And then on the other side there, the hernias, these are those actual holes where structures inside of the abdomen can kind of poke through. For these, people can have pain with these, but a lot of people I meet don't really have a lot of pain with them. Some people don't even notice they've had a hernia for a long time. So not super common to cause pain. So what do we do about it? I'll start actually at the bottom here. We're gonna work with pressure management. So we talked about how using too much pressure in the abdomen can sometimes make a hernia worse. It can also sometimes create a hernia in someone with that diastasis. So we're gonna work on how do we breathe, how do we safely lift and use our body so that you're not putting yourself at more risk for that. We're gonna work on core activation and strengthening, especially for the postpartum population I see. That core strength is really hard to get to come back in the right way that we need it to. So we'll work a lot on making sure you're activating your core in the right way. And then a lot of people I meet, or some I should say, they've had this for a long time and never noticed it. And so sometimes the core patterns they've been using have been so long-term that it takes us quite a while to just rehab how to actively activate their core, or appropriately activate. And then body mechanics. So I'll meet a lot of people that want to lift and want to move by just using their back. They don't want to use their core when they're moving, so re-educating a lot of those patterns. We made it. Conclusion. As a review, these symptoms are super common, but they're not normal. A lot of people chalk them up to being normal. You know, the example of our moms always say, hey, I pee myself, that's just a part of it. It doesn't have to be. Just like a lot of people say, hey, with age, you know, that organ prolapse, that incontinence, it's a part of it. It doesn't have to be. There are things that are a lot more popular now that we can do about it. Seeking out help from a pelvic floor therapist. So if you felt like anything from today's presentation felt like it resonates with you, you feel like you have some of these symptoms, anything from that screening tool kind of popped in your brain, it raised a little flag, seek help from a therapist. So to get a referral, this typically is coming from an OB-GYN for women. Your primary care can refer you, a urologist, a gastrointestinal doctor, really anyone you're seeing for any of these issues, physician-wise, can give you a referral. The state of Ohio does allow direct access to PTs, so you could just call our clinic and make an appointment. But I do know some health systems and some insurances aren't quite on board with that yet, so don't be surprised if there's a little pushback on that. I do find the easiest way, especially if you're going through a health system, is just to get a referral from your doctor. And usually, especially I've had a lot of people where their doctors doesn't necessarily bring it up, that's getting better, but where patients brought it up themselves and said, hey, I've heard about this thing, I'm really interested, could you refer me? That could be an avenue as well. Like we said, we are right down the street, us two, and we have one other coworker that's a pelvic health therapist. We're at the Kaufman YMCA. Miami Valley has a PT clinic there, and we treat all kinds of PT there, so we can see people after a knee surgery or for back pain, but there's 3 of us there that do PT. And then Premier itself has multiple pelvic therapists throughout the region, through Atrium, through Upper Valley up in Troy, and then with the Miami Valley system as well. Usually our website has a good directory of where to find everyone.
Yeah, one more thing to mention, if you did go see us at SureCare before, we did move over to the Kaufman YMCA recently. So that's where you would find everyone if you are familiar with those doctor's offices. And then online now you can schedule with your physical therapist, which is really nice. That way you don't have to call and wait, and you can go on and see our pretty pictures and choose who you want based off of what we treat and everything. So we just want to thank you guys for coming out and listening, because this can be a pretty hefty topic. So we really appreciate it. And floor is open to any questions.
Yeah, any questions that you have publicly, we'll take now, or if anyone wants to come ask us individually, we'll hang around for a bit after.